Dr. Philippe McMillan, good morning and welcome to Weird Sauce. Thank you for taking time from your location in United Kingdom, I believe, to have this conversation with us. And could you kindly introduce yourself to our audience here?
Thank you very much, Florence. I'm Dr. Philip Macmillan. I'm a physician in the United Kingdom. My focus is around general medicine, specifically stroke interest. And in terms of my background of interest and focus, it has been dementia research for about the past 12 years. And so I have an active interest in clinical research, dissecting clinical scenarios and trying to understand them by using research work that has been done by others. So it's very important to differentiate that I am not a researcher in the sense that I am doing experiments myself. I take research and I try and apply it into a clinical context.
So that's very interesting. So in the context of this conversation that we're having, not physically together in an office, either in the UK or in Singapore, one of the reasons why that is because we're also in the middle of a pandemic. Could you explain to our audience who may not be familiar with also the work that you've been doing in the past few months online to sort of share perspective on this pandemic with various guests? And could you tell our audience how you got to do that compared to your primary medical interest?
Yes, thank you. I think that in order to understand where I've come from, you have to think about the background that I've been doing. As I mentioned, for the past 12 years, I've been integrating theories and understanding with regards to dementia. So I've been presenting across the world. I was in in Canada, in Italy, in China, and I've been speaking about dementia from a unique perspective. And so it's just so happened that at the time of COVID, I had reached about the point of integrating all of that research with dementia and trying to put it together in a way that it could impact how we treat dementia across the world and how we understand and research it. So, with that background of doing that kind of research for the past 10 years, when COVID came, I was immediately curious. And because I knew how to synthesize research, I believed that if I could see the patterns of the disease and get information about the lab associations, that I would be able to come up with an understanding of COVID 19. Quite simply, I said to myself, if I can figure out dementia, pretty good chance I can figure out COVID. And so that's where I started from. And when the information started to come out of Wuhan, I was looking out for the research. And I remember when I got the first paper out of Wuhan, and I looked at the characteristics that were associated with COVID. And there were just two things that jumped out at me. And one of them in that very first paper was that 76% of the patients had hypertension and there were no children. And that to me was a very, very important point. And so straight away, I started to go from a different angle with regards to understanding COVID 19 and to get a picture of how I tend to approach a disease. You would look at, I tend to use type 1 diabetes as a template. If you just look at the fact that someone is passing a lot of urine, you would think that this is a disease about the kidney. If you then notice that the reason they're passing a lot of urine is because they have high amounts of glucose in it, you would think that this is a disease about glucose. You would then find that the blood glucose level is also elevated. Then you would find that the insulin levels are low. And so you could conclude that this is a disease about insulin deficiency, but that's only partially true. You then have to know that this is a disease that is associated with damage to the pancreas and the islet cells, specifically in the pancreas. And so usually symptoms are 4 steps away from primary pathology. And if you don't get to primary pathology, you won't be able to understand the disease. So my focus with COVID-19 was to get to primary pathology. What was it that was happening that was getting these patients sick?
And in terms of what we've been, because we've been in this 16 months, roughly speaking, we've been in this 16 months now, we've seen some evidence of primary risks, whether they're age related, whether they're gender related, whether they are obesity related or cardiometabolic illness, including type 2 diabetes, etc. So, in your opinion, have we now settled for something that has a very good set of pre-existing condition related to risks, or do you think we're still in the discovery phase of this?
I think when we look at the mortality across the world, it's pretty consistent. There are certain diseases that stand out as being almost always associated with high risk. And in that sense, I think that we can predict relatively accurately who is most at risk. And I think the Oxford algorithm, the Q COVID score, is a pretty good template if anyone hasn't seen it. It's still only a research tool, but it does give a pretty accurate picture as to what the risks are on an individual or personal level. And these are very closely related to comorbidities and age. And so, yes, I think that the pattern is about accurate across the world.
And in your opinion as well, prior to going into this, so you are focusing in dementia, and in my relative journey into brain issues related to glucocorticoids and chronic and acute stress exposure, which primarily is as the burnout experience that I've had to read a lot of long-term evidence of what happens with dementia as well and lifestyle behavior, whether it is stress exposure, physiological stress, or cognitive stress. Here in this disease, which obviously immunity is involved, we're looking to see that people with perhaps not ideal metabolic health are at higher risk of developing a serious illness or not responding well to it. How do you think that this will impact people's understanding of the relevance of daily behavior into a health, whether something that is related to aging or something that's related to an acute crisis like a COVID-19 or a pandemic?
Yes, it is an interesting point. And if there's one thing that has come out of COVID-19, I've had a research colleague mention the word that this is not COVID-19, this is comorbid 19, because it is a disease that is so closely linked to comorbidities. And we see generally, if you are in good health, your risks are significantly lower than if you have associated comorbidities. And I guess as we progress in our discussion, I'll be able to explain some of the reasons why I think that is so. But certainly, one of the very interesting things that we have not done is that in the past year and a half since the crisis has started, we have focused on many different forms of treatment, but we have not implemented and insisted and pushed strategies that would help people to become more healthy in their daily living, regular exercise routines, looking at what you eat. These are things that are of great significance with regards to reducing the risk, not just of COVID-19, but of almost every other associated comorbidity. So that's an opportunity that has probably been missed, and one that should be actively taken up across the world to encourage more healthy lifestyle.
I think that's a very apt observation, because I was wondering, we're now here in Singapore in a second more rigid sort of, I wouldn't call it lockdown, but we have restriction, very strict restriction because of another peak of new cases. And the first thing that got shot after FMB outlets were gyms and things, including outdoor things like swimming pools and stuff like that. And it again, like this, the first wave, the immediate response was like, I understand the response to the risk of enclosed door, but the sense that the first thing that gets taken out is the ability to go, and do exercise, which is good for you. The ability to maintain a mobility routine, never mind physical exercise, is essential. And then the retrieval on comfort, which I discussed with other doctor, which the first comfort is food, and probably not a broccoli or plate of healthy salad and fresh food. So are we not in a loop by default of responding to measurements that have kind of basic good sense originally, but because we're in a complex system, linearly, they actually don't add up to much good? What's your view on that?
Yes, I would agree. And I think that, as I mentioned again, my dementia research, one of the very important points that has come out of it is the fact that in order to have 50 million people across the world, with numbers likely to double every 20 years, so that means 100 million people in 2040 with dementia, across the world, we must be dealing with an environmental pattern. And the pattern that is in existence with dementia is the final outcome, is very strongly again associated with comorbidities, diabetes, hypertension, heart disease. And so what we are seeing is a continuum of disease that extends across the whole world. What we have at the moment in terms of medical research is that we have become comfortable with regards to finding treatments for disease and not necessarily finding the root cause and identifying why disease is so prevalent. And so there are two huge challenges in front of us. One of them is that there is no way that we should accept type 2 diabetes as being just a part of people's lives and the associations with obesity and metabolic liver disease and so on. And the second thing that we have to answer is, why is it that across the world there are so many people who are vitamin D deficient, which doesn't make any sense in the context of people who are exposed to sunlight, even on the equator as in Brazil. It indicates that there are patterns that are in place from an environmental point of view that need to be addressed. And that's what I mean when I say that we have to be able to analyze root cause problems to be able to find real solutions, not just for COVID, but for many of the diseases that we have grown to accept as being part of life in the world. I don't think that's acceptable any longer, and it needs to be challenged.
That's a very good point. I think that it needs to be challenged, absolutely. How the dichotomy of power between those who can challenge and those who are to be challenged, I think that in itself is going to be a big challenge. But point taken, absolutely. I absolutely concur with that. Now, on a tangent from this, understanding that you were closely observing the relevance of metabolic health, maintenance of metabolic health, good metabolic health, in order to preserve brain and not accelerate brain aging. How did you personally respond when you realized something was going to be bigger than perhaps swine flu, perhaps other alert that we had around pandemic? What was your thought process when within maybe January or February of 2020, you realize, okay, so now we're going into lockdown, there's lots of things that are changing, as a physician and as a person?
That's an interesting question for me personally. And just because of what I was doing at the time, interestingly, when lockdown came, I found that my life didn't necessarily change a lot, because a lot of my work was around work in terms of the hospital. And when I was at home, I was focused a lot on research. And so, in effect, that pattern continued. So, that's probably one of the reasons why, even throughout the pandemic, I've been able to maintain a degree of focus because I was able to maintain a consistent pattern. And in that respect, I do understand that many people, especially who are quite used to being in social circumstances on a regular basis, would absolutely have been struggling with being locked in their house, sometimes in an apartment with limited contact. Those are things that would have quite a significant effect on other people. But for me personally, I saw what I think was an important opportunity. And the opportunity that I was looking at was that I recognized that the approach that I had with regards to dementia needed to have its awareness raised. And I recognize that if I can therefore tackle COVID, demonstrate the approach and the principles of research, there you have the opportunity to therefore also raise the research profile of what you're doing with dementia. So I saw the two things as working concurrently. And in a certain extent, as you can see, we are talking about COVID, but I'm also getting the opportunity to speak about the dementia research, which is also just as important. So, from a personal point of view, this year has been an opportunity for me from a research and clinical point of view. But I can imagine for most of the world, lockdown was extremely difficult.
And I've for those listeners who have not who are not familiar with your YouTube videos where you interview a lot of clinicians from around the world, a lot of scientists on the specific topic of COVID, which I've been following very intently because I've been educated so much through them. So I strongly recommend that people check those links out. What surprised you the most, considering your background, not just as a physician, but the specific background of understanding dementia as an evolution illness? And what have you learned from these physicians around the world while jumping into this?
I think that my experience, truthfully, has been very unique. And I have been doing research focused on COVID-19 from a specific angle, but I've been speaking with experts all across the world. And to put it in context, one of my earliest interviews was with Professor Yufang Shi in China. So I got to understand what was happening in China, I got to understand his thinking. I was speaking with people in Canada, in Europe. I went on to speak to professors in Australia, I spoke to a PhD in Japan. And what happened is that every time I had a conversation, it opened my understanding a little bit more. And if there's one thing that I have then gained over the past year or 18 months, is that I have got a very broad understanding of the different theories and concepts with COVID 19. Every conversation has been a learning experience for me. I have walked away from it thinking, wow, let me add this in to the research that I'm doing. Let me see how to integrate that, how to learn from that, and how to expand the theory. So it's not just been theoretical work, but I have been taught and educated by all the people that I have spoken to. So, yes, it has been a tremendous experience speaking with experts like that from every aspect of the world.
And were you particularly surprised by the either the similarities or the differences in both the understanding of the illness early on and the structure that were being put in place in each of these countries in order to act and respond to help patient? Could you take us through this journey for you, because it certainly was very stunning to me to see that depending on the country you were looking at, we had very different approaches to treatment and management of this illness, if any, if any.
One of the very interesting things was that when the world first looked at Wuhan, nobody thought that the strategy of lockdown would ever be implemented anywhere in the West. It looked completely strange. It had never been done before. But Italy, when Italy was hit by the pandemic and we saw the devastation, it was very, very difficult to not do a lockdown and take stock of what was going on. In terms of what has happened with Western countries versus many of the other countries, say for instance on the Eastern Hemisphere, is that their approach to spread and management of viral infections seems to be inherently in place. I'll give you an example. When you looked at Japan up to December, I mean, it has changed at the moment, but up to December last year, when there were almost 300,000 deaths in the United States, Japan had 2,456, something like that. And what it turned out is that the Japanese, for one, have as their cultural base is that if they think that there is a risk that they could have an infection, they tend to wear a mask. That's not something that has ever happened in the West. And two, they very quickly recognized that close quarters was a significant part of transmission. And so they put in ventilation to try and see if they could minimize that. So they employed some strategies that were relatively easy for them to do, but not so easy to do in other parts of the world. And so when we look at Europe and America, the options that were available were relatively crude in terms of lockdown because they needed to mitigate the spread of the virus. That was the only way that they could do that. The other thing that stood out was the lessons learned from Italy. And I was surprised that we didn't take those lessons very early, which was that in Italy, what they found was that the hospital became the epicenter of the pandemic. So effectively, the hospital workers got infected. And as patients came in, even if they weren't infected, they then spread the infection to the patients, which then took them back to the community. And very quickly, they realized that having the staff well protected was essential to trying to control the disease. So it is partly the lockdown and partly the fact that we probably didn't recognize the fact that hospitals became an epicenter and needed to be very strategically managed. That was part of the reason why we had such severe outbreaks in different parts of the world. In certain other parts of the world, they had very, very active contact tracing. And again, it's down to sometimes characteristics of a population. Some populations are far more open to giving information, allowing that information to be shared, and therefore making it easier for governments to be able to identify and keep people from spreading it further. And we can see some of the success that occurred in, I think, South Korea, in even Vietnam, Malaysia, quite early on in the pandemic. They didn't have quite severe outbreaks because they were able to mitigate the spread very early and control it. That's a challenge that will keep on coming, as we see, because it doesn't mean that because you are successful the first time, it doesn't mean that you will be successful in the future. So the challenges are still ahead of us.
And in terms of treatment, one could be taken aback by some of the statement that I kept on hearing very early on, which is that some of the recommendation that we're giving to patient was, if you're positive, go home, stay home, and come back when you can't breathe. I mean, in some version of that, depending on the country. And it stunned me listening to various physicians who were already treating COVID patients straight from their practice. Some of their comment was that this was the first time they've ever heard in their practice of medicine that we would tell people to wait until they were so unwell that the options was only to put them into a hospital, possibly into a ventilator. So what's your experience talking to so many people, and perhaps also your personal experience around your environment in the UK, of this very strange issue, particularly related to COVID, which was we were told to go home and wait for us to get worse or better.
I do understand that perspective. I have heard similar discussions. However, let's put it in context. When someone has flu, we tell them to just go home, take simple medication, and wait for yourself to get better. And even within the context of COVID 19, the challenge with COVID 19 is that the majority of people are asymptomatic and largely well. They don't move on to severe disease. And so, therefore, the initial thinking of, yes, let's just wait and see, could be considered reasonable because not everybody who gets the infection will get severe disease. What we probably could have been better at doing was identifying the comorbidities to look more closely at the people who were at higher risk. But as I said, that was an evolution of understanding. And you could understand in the first wave, that was the response. But we should have been better in the second wave. And in the second wave, we should have been far more strategic with our thinking in terms of identifying people who were unwell and doing something a bit more active about it. Now, again, this is the lesson that I learned from looking at China. This is something that is not well known, not because it's not out there, it's just because people don't look at the research. As much as we have issues with the data that may have come out of China, one thing was very clear is that they took the infection very seriously. And if people were positive, they didn't send them home. They isolated them from their family because their view was that don't go home to spread it further. They were kept in isolation for up to 2 weeks. I think that was an extremely important part of the strategy. And so, similarly, I have always said that even in the Western world, even though it's more challenging, rather than sending people home, we could have used facilities, hotels, which weren't being used, to isolate people to try and prevent the community spread of disease. And even more so, if we had people who we knew were potentially high risk to therefore deteriorate, we could have isolated them in locations where we could keep a close eye on their blood parameters and so on. So, not necessarily in hospital, but in another facility that you are observing, knowing that a percentage of them are likely to deteriorate. So, yes, I think that initially, I think, as I've said before, hindsight is 2020. The first time something happens, you often just respond. But we've had the opportunity to have two bites at the cherry. And I do think that on the second occasion, we probably could have been far more strategic with the way that we approach the disease if we had a better understanding of it.
A lot of people here in I think not just in Singapore but in general, their first assumption, if they're not in medicine, is that their understanding, if I may say so, is that this is a disease that doesn't have any treatment, prophylaxis treatment. It has a treatment when it's declared and it started to evolve, but there's nothing we can do to prevent it apart from not being exposed to it. And there are no drugs that can be taken that may make us feel better or diminish the symptoms, and therefore it's extremely scary for a lot of folks to imagine that here is this big virus that can put you into hospital on an incubator, and we seemingly approaching this with no drugs at all apart from a very late stage. Is that perception correct? And if it's not, or if it is, then what's your view on this concept of where this perception is now been about? There's nothing much that anybody can do about this right now.
That to me represents the piece of history that when we look back at COVID 19, is going to be challenging to justify. So, before I speak about treatments, one of the fundamental principles that I've had is that you cannot treat a disease that you do not understand. That is essential. So, we missed an opportunity in the first wave and even the second wave to be able to spend the time and the resources to really understand the disease. What was very clear to me was that you had a very high number of people who were asymptomatic, or you could call subclinical infections where they didn't have any symptoms. But from the research, it indicated that they still had inflammation in the lungs. That's a very, very important point. And what we did is that we did some autopsies on patients who died. We've done lots of serum sampling, but we have not spent the time to study the asymptomatic phase of the disease. That is an absolute error in our thinking, and that has come back to haunt us, because without that understanding, you can't fully understand the disease. The principles that we are looking at now with our research, and just to give it some context, is that we are focused on an autoimmune response in COVID-19. We could call it hypersensitivity. It's very well accepted across the world that the cytokine storm is your immune system that does the damage. The question is, what triggers this cytokine storm, or as we say, autoimmune or hypersensitivity response? When the research first came out, as I mentioned in Wuhan, it was clear that people with cardiovascular complications and diabetes were high risk, and children were not. That to me stood out as an outlier. And it meant, therefore, that whatever theory you had of the disease had to explain why those younger people didn't get severe disease. Now, a lot of people think it's just because their immune systems are stronger. And I challenge that, because I say that one of the weakest immune systems are in infants, less than 1 year old, or even in the first 28 days, because they only get antibodies from their mother, and they haven't built their immune system. And so in every single viral epidemic, or any kind of epidemic, you have a U-shaped curve, in that you have infants dying and you have elderly people dying. This in COVID was very unusual. To put it into context, up to the data recently, when I looked at 127,000 deaths in the UK, of that number, only 2 infants died. That is remarkable. And so we have to first understand, why is it that this group is not affected compared to the older group? And this is where I stumbled into this piece of research. And as I said, because of how I do clinical research, I look for outliers, and then I try and understand the outlying information, and then bring that under an umbrella of a concept. And what I found was that one of the only differences between the young and the old was something called serum, or soluble ACE2. Now, to put it in context, this is a bit of science. We do understand that the virus uses its spike protein on the surface of the virus. It uses ACE2 to get into the cell. And that's how it infects the cell and then spreads. So ACE2 just happens to be an enzyme that is very important in regulating blood pressure and inflammation. And it just so happens that the virus uses that enzyme to get into a cell. What we had failed to understand was that in certain comorbidities, instead of the ACE2 just being attached to the cell, the body clips off a percentage of it so that it floats in serum. That's what we call serum ACE2. Now, serum ACE2 is very important because a recent paper in the Lancet across the world, is a very good study, demonstrated that as serum ACE2 rises, the risk of cardiometabolic death rises as well. Actually, it is the most predictive factor for cardiometabolic risk for any person if their serum ACE2 is elevated. And that's what gets people confused. They hear ACE2 and they think it's cellular ACE2. Yes, that is there. But serum ACE2 is floating in serum, and it's likely to be a compensatory strategy that the body uses to manage the levels of angiotensin II in the blood. But it only rises in specific comorbidities: diabetes, cardiovascular disease, kidney failure, obesity. This mirrors perfectly the people who have severe disease in COVID-19. Now, what we are looking at is that if you have a virus getting into the tissues and the bloodstream, and you have high levels of serum ACE2, does it also bind to the spike protein of the virus? And if it does, what happens when that virus is picked up by your immune system? How does it differentiate the serum ACE2 from the spike protein? And that's why we say that it looks like this is a viral mediated autoimmune response. Your body then thinks the serum ACE2 is part of the spike protein and makes antibodies to it. And this is what our research has been focused on, and this is what drives the cytokine storm. And so, if there is no understanding of this, it is very difficult to find a treatment. And it is therefore very strange that the only treatments that we have, or the primary treatments that have been accepted across the world, are one, dexamethasone, and two, tocilizumab, which is a drug that is used in rheumatic diseases to manage the inflammation. So two drugs that manage inflammation are likely to be our only candidates that make a difference. And all the antivirals that we have tried, none have seemed to make much of a difference in terms of mortality. So my first challenge has been, and this is what I've been speaking about now for over a year. I saw this in April 2020. I recognized this autoimmune response, and I have consistently been talking about it for over a year. However, the scientific world is like the Titanic. It is very difficult to change direction, and it is only slowly in the past maybe 5 or 6 months, as more and more evidence is coming out about autoantibodies in COVID-19, that people are starting to recognize that this is an autoimmune disease triggered by the virus. I said it in April 2020, and I'm still waiting for our community to accept this as being the primary cause of the disease. But you have to wait and you have to work. So that's an important framework to then discuss about treatment. If you don't understand that, it is very difficult to find a treatment because you don't know what to treat until someone gets sick. And this has been, I think, part of the challenge that I have seen, even with people who discuss outpatient treatments. The problem they had is that they still couldn't explain why. And that's an issue from a scientific point of view. You need to understand the mechanism of the disease. And if you don't understand the mechanism of the disease, people would then ask, why are you risking giving people medication early? So in that context, identifying a treatment that works is important, but even more importantly, I ask, is not that it works, I ask why it works. Because if we understand why it works, we can then look at other drugs that could do a similar thing. And that's the way that I would approach it. So I understand the challenge that exists within the structure of healthcare organizations to then give license to a treatment. But that confusion or that challenge was exacerbated by the fact that we didn't understand the disease. And how you check that is that anyone who agrees with the use of steroids, which almost everybody agrees with, ask them why. Why in a viral infection are we using steroids that has never worked before in any other viral infection? Even in severe influenza, if you give them steroids, it doesn't work. But yet it is the primary treatment modality across the world in a viral pandemic. If they don't have an explanation for that, then there is a problem with their treatment, because I would ask them, what is the basis, therefore, for what you are treating? And that's been the challenge as to why there's so much confusion, is because we haven't done our homework. If we had done our homework, if we had been doing the autopsies on asymptomatic patients who happen to have died as well, looking at their lungs, seeing the inflammation, looking at the cells, it would have been very clear the pattern as to what was happening. We have done a lot of assumptions in COVID-19. I think that's been the mistake.
So 16 months on, especially with your ears out to the world, and being exposed to a lot of people's experiences, as well as researching it yourself, and also living in, I believe you live in the United Kingdom. So this is one country where the decision to act very decisively on vaccination has been at the forefront, similarly to Israel, I think, which is just before you in the United States. What are your thoughts about the concept of the vaccination as a tool? Because what you're hearing now from politicians around the world and from healthcare establishment, I suppose, is the only way, and I think I'm going to repeat a mantra that I think pretty much we hear throughout the day on various media, the only way out of this is through vaccination. So I would like to hear from you, what do you think about this? And then the second part to that question is also that we are now facing different type of variant that were not present or were different in January or February of 2020. And therefore, the reality of these two things concurrently existing, the vaccines and their mechanism and their different type of vaccines, and variants that keep on popping up and mutating, what is these two situations concurrently existing represent as a risk for the population? And if you are a person there in the population, what can you do?
That's a complex question. And again, I always start with a root cause analysis, understanding primary pathophysiology. In order to understand how the virus works, or in order to actively work to prevent the pandemic or to stop it, you need to understand how the virus causes severe disease. So I'll give you an example, and then we can think about how this fits. The most important trigger for your body with regards to a viral infection is a protein called interferon. Interferon is, if a cell gets infected, what it does is it secretes interferon, which warns other cells that, there's a virus around. Shut down your protein making machinery so that you don't make virus. And so the body then produces lots of interferon, all the cells shut down, and therefore the virus can't replicate, and then the immune system can pick it up. What is unusual about this virus, and similarly with SARS-CoV, they both evade interferon. Now, it's very important. So the virus gets to the nose, it replicates, it then spreads down into the lungs. One of the interesting facts is that even though we know that the nose and the throat are the primary locations for viral spread, less than 5% have a runny nose. And that indicates that the virus is able to evade your body's normal trigger. That's the interferon. So your body doesn't realize the virus is there until it has hit the lungs. That's at about 30 hours. Now, the interferon is like an air raid signal, if you think of World War II. 5 minutes before the bombers reach the city, the air raid signal goes off, everybody goes into their shelters. The bombs then hit, it damages buildings, but it minimizes death. In COVID-19, the equivalent of switching off the air raid signals has occurred. You only realize that the bombers are above you because the bombs are exploding. This is what your body is facing, and it then goes into an all-out immune response. So what that indicates is that the most critical piece of that puzzle is mucosal immunity. Now, many people don't understand that your immune system functions almost as independent levels. Your airway mucosal system is like an independent immune system. It's different from the rest of your body's immune system, and it's also even different from your gut immune system. So you have 3 immune systems in the same body. Each one of them has a different function. In the context of viral infections, your mucosal immunity is critical because that's how the virus enters the body. If you've got mucosal immunity, what your body then immediately does is secretes a specific antibody called secretory IgA. That's different from what we're talking about with IgG in the serum. IgA is in the mucosa, and that will trap the virus and prevent it from spreading and preventing it from infecting the lungs. The truth is that, and I've learned this from speaking with the experts, is that a vast majority of people, sometimes some people estimate up to 90%, already have exposure to any coronavirus, and they have mucosal immunity. So you may be dealing with either 10 or 25% of the population who don't have mucosal immunity, who are therefore at risk for severe disease. That's the first thing. When you then think in context as to our approach with regards to vaccination, we need to know that the strategy there is to build IgG. So by injecting in muscle, the body responds and produces large amounts of IgG, which prepares the body for exposure to the virus in the future. The challenge is that creating immunity in the body does not mean that you've got immunity in the mucosa. And one of the issues we see is that absolutely with the vaccine, we've seen reduced transmission, but it hasn't stopped transmission. And part of that reason will be because most likely the serum levels of IgG post-vaccination are so elevated that it's going into the secretions in the saliva, in the mucosal secretions, and it's having an impact on the virus being able to bind. That's good in the short term, but what happens months down the line when the IgG levels fall? We don't know. And if you hadn't got mucosal immunity before, can you still get infected? And will the virus still evade your interferon response? And these are things we still don't fully understand. So I understand the principle of vaccination. I understand the importance of it, even in the context of COVID-19. And as far as I'm concerned, for high risk patients, what choice have you got? Our challenge is when we look at using it as a strategy to get to herd immunity. That's the bit that needs to be analyzed very carefully to understand exactly what is required to have herd immunity. The viewpoint that I have come across as well is that we risk, in the context of vaccinations, to increase variants. And that's one when I'd spoken to Gert van den Bosch, who is a vaccine expert. And his science is pretty straightforward. I still can't explain what the risks are, but the principle is simple, is that if you have virus circulating freely and you are then vaccinating people, what then happens is that they have about 3 weeks before their antibody level builds up. So if they get infected before their antibody level reaches peak levels, instead of the body completely eradicating the virus, it may happen that the virus is still able to continue to replicate, but it uses mutations to try and get around the immune system. Similar to what we could see with antibiotics if we used too low a dose with bacteria, or we used an inadequate course, you increase the risk of bacterial superinfections. His concern was the risk of viral mutations, which could lead to super viruses. That has been challenged. I am not an expert on that, but we have seen a rise in the number of variants across the world. It's unclear whether or not part of that is related to vaccination, or whether or not it's just the fact that the virus is freely circulating and we don't know. The point is that as the variants increase, that risk of breakthrough infections continues to increase. When we set up what we call a Plan B group in February of this year, we got a number of scientists together, and our perspective was simple. What is our contingency? Our hope is that the vaccines will work and they will get past the pandemic. But what if it doesn't? What is the contingency? What do we do if? And in every scenario like this, we absolutely must have contingencies. I think that the problem that governments have is that they have to drive this forward because they genuinely hope that this is the solution to getting out of a global pandemic. But at the same time, we have got to be aware of the fact that it may not. And what do we do if it doesn't? So within that paradigm, I believe that there is still time to develop the Plan B of mucosal vaccinations. We have the technology. We would then use either the full virus or viral spike protein activated virus, and you spray it in the nose. And what you then are trying to do is build mucosal immunity. And that could be a far faster and more effective strategy at preventing the pandemic, because that's what is described as sterilizing immunity, because you can't get the infection and you therefore can't transmit the infection. That could be a much more effective way going forward at a global level to be able to manage carefully what is happening with the pandemic.
And would that work as effectively a universal stoppage to some extent for many other options or variants that we may or may not be aware of, because we're not genetically doing the phylogenetics of all of the variants that are out there. So, could we imagine that rather than waiting for this universal vaccine that a lot of people are talking about, that this mucosal aspect of a vaccine distributed nasally would be the solution to a universal vaccination or universal protection, because you are basically blocking transmission once and for all?
Yes, so this would be the ideal. Now, don't think this is easy because they have tried mucosal vaccinations before, say with the flu vaccine, and there are logistic challenges with regards to the size of the aerosol particles, whether or not somebody has mucosal secretions at the time that would even block the. So there are a number of challenges that exist. But what we have shown in the past year is that if we can come up with this many vaccine candidates as injectables, if we put our minds to it, we could do a similarly effective job with mucosal vaccinations. And absolutely, one of the misconceptions has been if one country controls the pandemic, is that adequate? Absolutely not. The world is too connected. So if India is having an outbreak, just as in Wuhan, it will come to the rest of the world. It is not good enough to think that you have done a job in your small sector of the world and you are safe. It doesn't work like that. Whatever strategy we are implementing needs to be implemented globally. And even in the context of what we have done with regards to vaccination, we have produced enough vaccine to have given it to every single person across the world who was high risk. But we haven't done that. And that to me represents the fact that we are still in silos of thinking. We are still focused only on our locality when we are not seeing the fact that this is a global pandemic. If the outbreak kicks off in Africa, it will come back. And we need to apply strategies across the world. And that's why I believe that mucosal or nasal vaccines are an extremely good way forward, because they could be simple and they could be applied across the world at a mass scale relatively safely.
So, Dr. McMillan, to conclude this conversation that we had on a very fascinating, albeit a little bit scary topic of discussing a pandemic while still being in the middle of it, which I think our immediate ancestor never had the experience of anyway. So, to conclude, number one, I would like to ask you: are you optimistic as a physician, and are you optimistic as a human being? And my second question will be: share with our audience your own weird sauce for life, even in a pandemic.
I am very optimistic because I have been interacting with people across the world who are finding answers. Dr. Shetty in South Africa, I think, stands out as one of the most remarkable conversations that I've had, where a doctor in a semi rural part of South Africa was able to manage over 4,000 of his patients with no deaths, no hospitalizations, no need for oxygen. That is remarkable. And he applied, tried frankly, the reason I'm so impressed with it is because he was applying a similar principle to what I've been talking about, in that he was focused on the hypersensitivity response. And so he used high dose steroids with antihistamines to remarkable effect. So, in truth, the solutions, even for people who are getting more unwell, are already in place. It's just that the world doesn't necessarily believe that it works, but that's a different issue. But from a practical point of view, an understanding of the disease, and if there is any important point that Dr. Shetty has pointed out, is the eighth day. He describes that on the eighth day, if you had symptoms on the Monday, the next Monday or Tuesday, if you start to feel unwell, that's when you need the steroids or the immune suppression, because that's when we predict that the autoimmune response goes into full flow. And that principle of very early intervention at a defined time, and I differentiate that from people who feel a bit unwell and just start steroids, because that's what is happening in some parts of India. Steroids are not a joke. They are serious drugs. They come with side effects. They need to be used judiciously, and need to be timed, and you need to limit the amount of it to reduce the risk of complications. And so it is something that needs to be done with understanding rather than just randomly being used. So there is tremendous potential with that early outpatient treatment. And additionally, there is the challenge that exists with ivermectin. No, ivermectin has not been approved across most of the world, the FDA, the EMA, the WHO, but they haven't said it can't work. They just said that they need more trials. And so, if we can get the right funding to be able to do these trials, ivermectin seems to be one of those remarkable drugs that modulates our immune system and reduces the risk of severe response. And that's a very, very important part of the picture. So I think that the combination of what we're seeing with regards to vaccination, with regards to early outpatient treatment, and with regards to potential other drugs that can minimize the severity of the disease, I actually would say to people, I believe at this point, we can have a world, even with COVID 19, and have zero deaths. It is possible, but it requires us to think differently and operate differently. In terms of my word source for the day, part of my work has been identifying patterns of disease. And there's one important pattern that I have noticed that is very relevant. And the pattern is to do with food and diet. I have found in my clinical work that many patients who present with strange neurological symptoms often have a food intolerance. And I have just learned that that's just my anecdotal quiz. I ask most of my patients if they have issues, I ask them about their diet. And I have found anecdotally that the majority of symptoms are connected with this food intolerance. This is relevant to COVID 19 because it seems to also be connected to the long term symptoms in COVID 19. And so, therefore, the principle is very simple. If you have bloating, diarrhea, or constipation on a regular basis, you need to reflect very carefully on what you're eating, because you may just have an intolerance that is driving all of your associated symptoms. That's probably the most valuable piece of information I've been able to give my patients over the years, and one that I'm sharing with your audience as well.
Well, that's very good. And again, to be a little bit more personal on this front, Dr. Macmillan, would you share with us what what drives you every morning to get up and to carry on with what you're doing right now? What's a piece of a personal component would you share with our audience so that somebody somewhere in the world listening to this think, well, I may not be a physician, I may not have his capacity to understand scientific knowledge, but I can relate to this particular human component that you just gave me. So what would be that component for you?
Um, I think that it's just my consistency that I've learned over the years is that if you pick an area, and it doesn't matter what it is, it could be a focus on anything, just zone in on something and just apply time, effort consistently, you will find answers. And for me, pandemic or no pandemic, I would still be doing my research into dementia. I would then move on to other diseases. That is just my pattern. I just consistently, I enjoy doing the clinical research. And so for me, it's because I enjoy it why I do it. I can't imagine if I'd be able to do it if I didn't enjoy it. And so there's an inherent curiosity and a desire to always find an answer that drives me forward. And for every one of us, there will be that passion, that thing that we could do all the time. Even if there was no benefit to anyone else, we would still do it on our own. That's where the power exists in the world. If all of us were to develop that passion and to find a way to bring it to life over time, we would be a benefit not just to ourselves, but to all those around us.
Dr. McMillan, thank you very much for this very enlightening conversation. We wish you all the best with the research and your findings. And thank you again for talking to us from the United Kingdom.
Thank you, Florence. Appreciate it.
If this conversation stopped you in your track, share it with your network. You never know whose life you might change for the better. Thank you for listening. Stay curious about our next guest and stay curious about life.